Good evening, everyone. We welcome you to the January 2nd meeting of the Washington Township Board of Directors. Good to see you all. If you'd now stand, and I invite you to stand and join me in the Pledge of Allegiance.
I'm awfully warm for January.
I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Dee, if you'd take the roll call for us.
Director Stewart.
Here.
Director Nicholson.
Present.
Director Yee.
Here.
Director Epen.
Present.
Director Wallace.
Here.
Thank you, Dee. Our first item on the agenda tonight is the election of officers. This is a little unusual for us. We normally hold our board elections for officers in December, but with the appointment of Director Yee, we're at a point where we need to officially install her into the board of directors. So I'd ask Dr. Nicholson to present that, if you would.
Mr. President, I move for the officers as follows. President, Bernard Stewart. First Vice President, William Nicholson. Second Vice President, Michael Wallace. Treasurer, Jacob Epen. And Secretary, Jeannie Yee.
Thank you. Do we have a second?
Second.
We have a motion and a second. Is there any discussion among the directors? Then, Dee, if you would call the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Epen.
Aye.
Director Yee.
Aye.
Great. Jeannie, it's good to have you aboard. We'll now move on to our education session. Nancy, if you could introduce that for us.
Tonight, the board will be receiving the proposed fiscal year 2019-2020 budget estimate for Washington Township Healthcare District. This budget provides for net operating revenue in the amount of $477,041,000 and EBITDA of $50,112,000. This year, depreciation is budgeted at what is for us an unprecedented high number. It is $49,988,000. I'm going to stress that depreciation is an accounting entry. These are skewing our financial results in a highly substantial way. It has to do with bringing online and operating the Morris Lyman Critical Care Pavilion. It's not something that has surprised us. We were expecting this, but it is a big number. Bucking the negative trend of government entities, our funding contribution to the retirement benefits plan for our employees is $25,200,000. We're projecting operating income of a paltry $125,000. Our capital spending requests are budgeted at $7,802,000. These projections are all based on our understanding of what is now a profoundly volatile state of the economics of our healthcare industry, locally, statewide, and nationally. The budget supports our institutional commitment to the patient-first ethic, to lean, rigorous expense reductions, regional alliances, and strategic partnerships. It provides for the facility master planning and strategic planning initiatives that are necessary to secure the future of our healthcare district. There are some interesting discussions going on in our industry at the national level, being brought forward by the Medicare administration. They have been proponents of what they call a value-based system now for many years. But now they're getting a little bit more explicit about what that means. And the new operational explicit idea is that health systems and hospitals like ours should stop seeing people as patients and treat them more like members. It is something that is gaining currency in our industry, and fewer healthcare organizations are going to make a go of it under that kind of a model. Many of you would recognize it as Kaiser, where the rationing is not explicit and known, but certainly at work. And that's how that system makes money. You simply don't tell people what they aren't getting, that they might have had in another setting. I can speak to that from personal experience, having worked for them very briefly in the Los Angeles market, and I understand exactly where the bottom line comes from. Kaiser is essentially an insurance product. We don't have that conflict here. And decisions about patient care are made on the basis of the patient first ethic. It's that plain and simple. We're going to see the convergence of that idea and Medicare coming. Medicare Trust Fund is approaching bankruptcy. I think everybody knows that. And there haven't been any substantive discussions in Congress that have been made public about how they planned to address that shortfall. The Social Security Administration is also approaching bankruptcy. I think their time horizon is under 10 years. I think we are going to see impoverished seniors on the streets without health care in our lifetime. And for many of us, a lot sooner. We're going to see a lot of pressure to shift focus away from a system of taking care of sick people to one that touts taking care of the well-being of people, and money will be spent on wellness programs as opposed to taking care of the reason why we're all here, which is to administer to the needs of people who really are sick. I think there will probably be financial penalties for doing that as we get farther down the road with this. There will be a renewed focus this year coming from both Sacramento and Washington, D.C. on something they call pricing transparency. And as we get to a later part of our agenda, and the board is asked to take action on the Experian program, you will see that we're beginning to address that with the Experian product. And we'll get a little bit of an explanation about how that works. I think that it is very important for us to maintain the public's trust, and that program will help us maintain that. We have about 16 months to go before we have our national election, and I would say a tremendous amount for the healthcare industry is riding on the outcome of that election. We've seen the dismantling brick by brick of the Affordable Care Plan. You'll see that again tonight when we report our financial results, and you see how the amount of money that we're having to write off as bad debt has a very direct relationship with people being uninsured. These things are going to be the grist of the election mill. There will be a lot of discussions about it. There will be proposals by individual candidates on both sides of the aisle, and we'll see where that takes us. I think it's one of those things that's impossible to call in terms of projecting what we're going to end up with. I think it'll be a mess, and it'll take some sorting out. I think that the uncertainty of the regulations that govern the reimbursement in this industry and the ravages of the managed care industry and commercial contracting are going to necessitate an increased financial rigor around our operating expenses. And this is something that has gone into the development of this budget. It's not the end-all and be-all in that arena, but there certainly is a lot of it in this budget, and I predict that in the coming months and years, there will have to be more. I mean, who could have anticipated having our most productive product line converted to an outpatient service? Somebody told you that was going to happen 3 years ago, you would have laughed. Outpatient hip replacements, outpatient knee replacements. But here we are. And as we go down the line, we're going to have to look for new sources of revenue that are particular to the inpatient arena. And we are beginning to develop some of those. You'll see them in this budget. And we'll have to work on more. So as the environment gets more and more difficult to contend with, the management of the hospital has a really tall order on its plate. It's going to need all of its considerable talent and the help of the members of our medical staff to see us through this. I think that we're well positioned by not having given up our identity as an independent community hospital focused on the true needs of this community as opposed to the pretend ones that will, quote, make everybody more healthy except for the sick people, that we will be on an ongoing basis relevant to our community, but we have the strength of UCSF as our partner at our side. And I think that we got the best of both worlds when that partnership was negotiated. And so far, they have been an amazingly good partner. They've lived up to everything they promised and more. And it is a partnership that will provide some of the new service lines that we need in this hospital to replace the inpatient revenue that formerly was derived from the Center for Joint Replacement. And it is important that we attend to that relationship and keep it vibrant and growing. With that, I want to introduce our presenters tonight. We have Chris Henry, who is known to our public at large as our Chief Financial Officer. He's Associate Administrator of the hospital and CFO. He attained his Bachelor of Science degree from Cal State University East Bay in September of 1995 in Business Administration with an accounting emphasis. He worked in public accounting for 4 years, after which he was certified as a certified public accountant. He joined Washington Hospital as the Director of Accounting in May of 2000. In December of 2003, he took over the position of Controller. Since 2006, Chris has served as our Chief Financial Officer. In October 2010, he took on the additional responsibility of Associate Administrator. We also have with him this evening the Chief Financial Officer of Washington Township Medical Foundation, Daniel Nardoni. He graduated from Cal State University East Bay, receiving his Bachelor of Science degree in Business Administration with an emphasis in accounting in 1991. In August of 2013, he received his Master of Business Administration and Healthcare Administration from the University of California, Irvine. Dan spent 3 years in public accounting with Arthur Anderson, working in their healthcare practice, followed by 5 years with Sutter Health as a senior accountant. In 2000, Dan joined Washington Hospital as a senior accountant. After 5 years in this position, Dan was promoted to budget manager, and in 2009, he took on additional responsibilities as the director of budgeting and ancillary financial services. He was made senior director in that same role. He was promoted to the assistant chief financial officer in October of 2015, and then accepted the position of assistant CFO in the Washington Township Medical Foundation in October of 2017. And in May of 2018, he became the chief financial officer of Washington Township Medical Foundation. With that, I'll turn the meeting over to Chris.
Thank you, Nancy. Here we are again. Dr. Nicholson and I were talking on the way in tonight that the year goes so fast. Seems like we were just doing this, but here we are. You know, I want to make some acknowledgments before we get started. This was a challenging budget to put together, given the environment that Nancy just outlined. And our team took those challenges on tremendously well. First, I want to thank our management team. You know, it all starts with you guys, and I want to thank you for your timeliness in getting your work done, and to Dan and Erica. I want to thank you for your adoption of zero-based budgeting. You've all adopted that wholeheartedly. So thank you very much for your work and commitment on this budget. I want to thank the associate administrators, Kimberly Hartz, Ed Fayen, Tina Nudis, and Stephanie Williams. You know, you guys spend a lot of time working with your staffs in your divisions in getting these things done and making the tough decisions that inevitably have to be made every time we do one of these budgets. So thank you for your support in this, as always. I want to acknowledge Dan and Erica Nelson, our Director of Financial Planning and Analysis. They really are the ones hurting all these cats. You know, they're the ones getting us to meetings. They're producing schedules that we have to react to. It's really a lot of work and a heavy lift, and they put in a lot of time and effort into it. So thank you, Dan and Erica. And finally, I want to thank Nancy Farber. Excuse me. For 25 years, Nancy has led us through these budget processes. And she's done so using her intimate understanding of the inner workings of this organization, her vast knowledge of the environment in which we undertake our mission, her vision of making Washington Hospital the major medical center that it's become, and her deep commitment to serving our community and to the patient-first ethic as the guiding light of everything we do. Nancy, thank you very much for everything you've done. Okay, let's move into the budget. We always put up our mission statement at the beginning of this budget, and it's to remind all of us that our mission statement guides every aspect of this organization, including the development of this budget. The budget is the financial embodiment of this mission and provides the financial ability to go out and perform this mission in the environment in which we're dealing with. Let's get started on that. Let's talk about what's going on in Washington. Some would say not a whole lot, but there is this stuff going on in Washington. You know, uncertainty continues to prevail in Washington on many fronts, and despite holding a supermajority on Capitol Hill for 2 years, the Republicans have been unsuccessful in fulfilling their promise to repeal and amend the Affordable Care Act. They made several attempts at that. to no avail. So what they've decided to do is start working around the edges of the Affordable Care Act, and as Nancy mentioned, dismantle it brick by brick, chipping away at it where opportunities arise. One of those opportunities arose around the individual mandate. And the individual mandate, for those who aren't familiar with what that is, was a provision in the Affordable Care Act that essentially provided or required every American to carry health insurance in some form. And to the extent that they didn't, they would be fined in the form of a tax penalty. Well, last year this individual mandate was challenged as being unconstitutional, and the Republican administration decided they just weren't going to defend it. And so as a result, the individual mandate, which actually was effective in prodding some folks to go and buy insurance on the health exchanges, the individual mandate was declared unconstitutional and eliminated effective in January this year. Meanwhile, in November, as we all know, the Democrats regained the majority in the House of Representatives. So there will likely be no more discussion of repeal and replacement of the Affordable Care Act until after the 2020 presidential election, and possibly not after that, depending on how the election resolves. However, it's clear that there is a lot of concern on both the Democratic and Republican side around the high cost of health care. It's a major topic of discussion, and will, as Nancy mentioned, will likely be a major campaign issue in the presidential election. So to that end, last month, President Trump called on Congress to develop and pass legislation on a bipartisan basis to increase price transparency in healthcare and limit patients' out-of-pocket medical costs. Two Senate committees set to work on this, one of them being the Senate Health, Education, Labor, and Pensions Committee. And that committee has floated some drafts of a plan that includes 40 proposals that are categorized into 5 distinct areas in this plan. The first one thereafter is ending surprise medical bills. And surprise medical bills, also known as balance billing, occur when an individual comes to a healthcare facility that is contracted with their health insurance plan. They're in-network. The term would be in-network in their health insurance plan, and assumes that all the services they're going to receive will be covered by their health insurance. Sometimes, unbeknownst to them, they will receive services from a physician or other provider who works independently at that healthcare facility and may not have a contract with the individual's health insurance. And as a result, the patient gets a very large bill that's not covered by their insurance plan, and it results in a large out-of-pocket expenditure in many cases. So really, there are a number of proposals in the HELP Committee's package aimed at ending this practice. Another area of focus in the package is reducing prices of prescription drugs. Kimberly Hartz and I made a trip to Washington in February with a group of executives from district hospitals around the state. We went to talk to the California delegation in Congress about, many issues that district hospitals are facing. And I think the one theme that we found in the 2 days of meetings that we had, we met with a lot of our Congress people and their staffs. The one theme we heard from office to office to office was that there was bipartisan agreement that something needs to be done about the high cost of prescription drugs, and that everybody we talked to felt that something would get done on a bipartisan basis this year. So more to come on that. If it comes as part of this package, we'll see it then. If not, I think they may do something independently of this. There are a number of proposals for improving transparency in healthcare, in particular around pricing and bills. And Nancy mentioned the software system we'll be discussing a little bit later that is going to be one of our solutions to approach this. There is a number of proposals in the package aimed at improving public health. There are a number of proposals for grants and subsidies for organizations in the country to go out and educate people about healthy lifestyles, ways they can live a healthier life. So they're gonna take that on. And last, there are a number of proposals getting around improving the exchange of health information, particularly information about the development and sharing of best practices aimed at reducing the cost of care while improving outcomes. All of these things that we're hearing and all of these proposals that we're seeing are all aimed at reducing the cost of healthcare, not just for individuals, but also the government. And there's one item that's not being discussed that is a major driver of the high costs of healthcare. We've talked about this before, and it's the fact that Medicare and Medi-Cal payments do not cover the cost of providing services to Medi-Cal and Medicare patients. It's a significant shortfall, and what hospitals are forced to do then is turn to commercial insurance companies to recover that loss. And commercial insurance companies then turn around and pass those costs on to consumers in the form of higher rates, higher out-of-pocket costs. So, it is a significant component of the high cost of healthcare now. They simply will not discuss it, but it is a fact. Moving into California, California's economy remains very strong. We have a new governor with a different take on things from his predecessor, Jerry Brown. In May, he proposed a record $213 billion budget that still manages to set aside $1.5 billion into the rainy day fund, bringing that fund up to $16.5 billion. Governor Newsom, one of his campaign platforms was moving California closer to universal coverage and a single payer plan in the state. And there are a number of proposals that aimed at doing that, at least getting us closer. One of the proposals is the expansion of Medi-Cal coverage to young adults up through the age of 25, regardless of immigration status. This is a first-in-the-nation proposal. And the estimates are that this will add 90 to 100,000 more people to the Medi-Cal rolls at a cost of about $98 million. Another proposal is to provide subsidies to middle-income earners to help them buy insurance from the California Insurance Exchange. What this provision does is it increases the income limit for eligibility from 400% of the federal poverty level to 600% of the federal poverty level. In dollars terms, that's an individual earning $73,000 or less. Again, that's a first-in-the-nation proposal. Right now, there are no federal subsidies for people that fall in this bracket between 400 and 600% of the federal poverty level. His proposal reestablishes the individual mandate. We'll see how that goes, since that's been declared unconstitutional on a federal level. But the idea is that the fees and penalties generated from implementing an individual mandate will fund the expansion of Medi-Cal to young adults. So we'll see how that works. It also proposes a single purchaser system for Medi-Cal drugs, and this proposal is a little murky. There's not a lot of information out on it, but essentially what he wants to do is pull the administration of the Medi-Cal drug program away from the Medi-Cal HMOs and have the state manage it directly. Again, not much information on this, however. community clinics and the state's hospitals that serve a high number of the medically indigent, our safety net hospitals, are claiming that this move could cost them as much as $390 million a year in funding that they currently get through the Medi-Cal HMOs, and they use that funding to expand services to the medically indigent in the state. So again, not many details on this. We'll see how that develops. This year saw the passage of yet another state unfunded mandate in the form of SB 1152. This is a set of rules governing the discharge of homeless patients when they come to our emergency room. Prior to discharge, this bill requires us to provide weather appropriate clothing if the patient doesn't already have it. Hospitals are required to provide vaccinations and any needed supply of medications. Hospitals are required to arrange for housing prior to discharge for homeless patients and provide transportation to get them to that housing in a radius of, I believe it's 30 miles. No one can argue that these aren't good things for the patients. These are good things for the patients. The issue is it's an additional cost levied on hospitals, mandated by the state with no additional funding or reimbursement. So we have estimated, this started in January, this went effective. We've estimated that for the 5 months ended May 31st, the additional cost of these provisions to Washington Hospital amounts to about $380,000. So this adds to the total cost of homeless care for that same period of $2.5 million for those 5 months. Annualized, we're looking at an additional cost from the new provisions of about $900,000 to $1 million. That's on top of the $5 million we already spend caring for the homeless in an uncompensated manner. So, the unfunded mandates continue, and this adds to a long litany of unfunded mandates and payment cuts that we've endured since 2010. We've seen this slide before. Wanted to give you a snapshot of where we think we're going to be by the end of 2020. And the estimated cumulative impact of the unfunded mandates and cuts in payment amount to about $802 million over that period. Those are big numbers that we're talking about. Of course, the largest component of that is related to California seismic requirements. And years ago, we knew we were outgrowing our emergency room and our critical care facilities. And we're planning to build new facilities, larger facilities, so we could accommodate the people here in the district. The California seismic requirements dramatically changed that project from expanded facilities for emergency room and critical care to replacing our entire hospital. Now, that phase 2 of that plan for Washington Hospital culminated in the opening of the Morris Hyman Critical Care Pavilion in November, and what a great place that is. It's a wonderful place for our patients to heal, for our staff to work, and for visitors to come support their loved ones while they're in the hospital. Absolutely amazing place. We're very proud of it, but it comes at a cost. And we started incurring that cost here in fiscal year 19, and beginning in when it opened in November. And we're estimating an additional increase in costs for fiscal year 20 of about $12.5 million. This will be the first year, fiscal year 20 will be the first year that we bear the full cost of having opened that building, and that's estimated at about $36.5 million a year. Two of the components of that cost, interest and depreciation, amount to $32 million of that, and I want to talk about those because they're related but different. These are both, as Nancy mentioned, accounting entries, neither of which represent additional negative cash flow to the organization. Interest expense, we've been paying on the loans to build that building for 3 or 4 years now. This isn't new cost. What's changed here is during construction, interest expense is accumulated on the balance sheet, and once the building opens, is amortized over the life of the building, in this case 40 years, as part of depreciation. It's accounted for as part of the cost of building the building. Once the building opens, we stop accumulating it on the balance sheet and bring it right to the income statement. So again, it's not a change in what we're paying for interest. We've been paying it for years. It's just a change in how we account for that. Likewise, depreciation is not a cash flow item. Depreciation is the recognition of cash flows that have occurred in the past, in this case, building the building, that are then amortized through the income statement over that 40-year life of the building. So those two items are not changes in cash flow. They are, however, accounting changes and increases in our expenses from an income statement standpoint. The remaining $4.3 million are changes in our expenses, true changes in our expenses, and they're the costs of running that building. They include labor, utilities, securities, supplies, IT-related licenses, all the things it takes to run that building. So again, this year, the full load of the $36.5 million is hitting the income statement. And then, as Nancy mentioned, this isn't a surprise. We anticipated it. It is not something that any hospital who had to build a new building to conform to California seismic requirements isn't facing. It is just a reality of life there. And again, as I mentioned, this is all happening. This is a state mandated requirement. It's all happening in an environment where Medicare and Medi-Cal do not pay us enough to even cover the cost of providing care to their insureds. For fiscal year 2019, we've looked at this slide every year. For fiscal year 2019, we expect that shortfall to be in excess of $154.5 million. Now, that's not a shortfall from charges. That's a shortfall from cost. And that number last year amounted to about $130 million. So the opening of the critical care pavilion is widening that gap, and we expect it to continue to widen in 2020. Moving on to the East Bay, we always look to the East Bay Economic Development Alliance for their forecast on what's going on in the East Bay. The East Bay Economic Development Alliance is a group that's aligned with Beacon Economics, and they really focus on what's going on in the economies of Alameda and Contra Costa County. And this year, the East Bay Economic Development Alliance predicts that job growth rate of 1.5% will continue through the calendar year, slightly better than the California rate of 1.4%. East Bay, they also predict that East Bay unemployment will remain below 4% through the calendar year. Unemployment in both the East Bay and the district ticked up slightly this last year. In the East Bay, unemployment at 3.4%, in the district 3%, but those are still well below the state unemployment levels of about 4%. Unemployment, by the way, peaked in the district in 2009 at 9.7%. So really those numbers are very good compared to what we've seen in the past. Overall, the Alliance says that the key economic indicators are positive and the gains are expected to persist in the long run. The one thing that the Alliance doesn't look at and has missed is the prevalence of homelessness in Alameda County. This year, the biannual count of homeless occurred and was reported, and it appears that homelessness in Alameda County grew 43% over the last 2 years. We all have seen it. We've seen the motorhomes, we've seen the people in our ER. It's really becoming a problem. That the numbers have increased from about 65 5,600 individuals in 2017 to over 8,000 in 2019. And the report estimates that if something isn't done about the high cost of housing and the lack of affordable housing in Alameda County, those rates will continue to grow at a rate of about 1,500 people per year. These are people like you and me, their mothers, their fathers, their children, their brothers, their grandmothers, their grandfathers. It's going to be an issue and a major topic of discussion in the county and here at Washington Hospital, because ultimately we need to care for these folks. This year, Washington Hospital continued to distinguish itself in a number of areas. Our orthopedic programs continued their run. There's an amazing run between our orthopedic surgery and joint replacement programs. This year, both were awarded Health Grade's 100 Best Hospitals Awards. That puts our orthopedic surgery program in the top 10% of the nation for the 8th consecutive year, and our joint replacement program in the top 5% in the nation for the 7th consecutive year. These are just incredible runs. Those two programs were also awarded Health Grade's Excellent Awards for the orthopedic surgery program. That's the 6th consecutive year for them to receive that. And for our joint replacement program, the 12th consecutive year. Washington Hospital was also recognized with a Health Grade's 5-star rating for the treatment of sepsis for the 4th consecutive year. So year after year after year, these programs are continuing the high quality of care that they've been providing to the district, and it's just amazing the runs that they've had on these awards. Other recognitions this year for Washington Hospital received 2 from Program Beta and their Quest for Zero quality programs. Both our emergency department and OB departments were recognized by those awards. These are not easy to get. There is a series of pretty difficult quality metrics that they have to meet. It takes a lot of hard work and dedication. These are awards that we've also received year after year after year, and congratulations to our clinicians in those 2 departments for meeting those metrics. Once again, we received a Practice Green Health Partner for Change Award for our efforts at establishing and growing our green practices here at Washington Hospital. That effort's led by Paul Kelly. And a lot of hard work goes into that, so congratulations to Paul. We've received this again for numerous years. 20 of our physicians on Washington Hospital's medical staff received Best of Fremont Awards, and it's a testament to the quality of the physicians we have working here. I'm sure that's very difficult to decide who because they're all so very good. So congratulations to our physicians on that. And we are awarded a particular honor from the American College of Surgeons Commission on Cancer. We received an Outstanding Achievement Award during our accreditation process this year. We're one of only 24 hospitals in the nation to receive this award. So our oncology and cancer programs really performing at top level. So let's move into the numbers. This year, our budget, Nancy mentioned some of these. This year, our budget provides for total operating and non-operating revenue of $504 million. It provides for the funding of new capital spending requests in the amount of $7.8 million. Provides $25.2 million for the funding of our retirement plan and our post-retirement health care benefits. It provides $17.7 million for the debt service on our revenue bonds. It provides or anticipates property tax revenue of $16.8 million for the debt service of our general obligation bonds. It provides for hospital earnings before interest, taxes, depreciation, and amortization, EBITDA, of $50.1 million, and hospital operating income of $160 million, a total bottom line with a net loss of $474,000. It provides funding of $22.3 million in support of our development corporation, and it keeps us in compliance with all of our bond covenants, particularly the debt service coverage of 2.8 to 1. This is a quick roll-up of what the income statement looks like. Total operating revenue increasing about $13.9 million to $477 million. Our operating expenses increasing $16 million. That's about a 3.5% increase to $476,881. That includes those additional costs coming on from Morris Hyman Critical Care Pavilion. As I mentioned, it gives us an operating income of about $160,000. After non-operating activities are considered, we end up with, and Dan will get into the details of these, with a total bottom line showing a $474,000 loss for the hospital. After the funding of the development corporation, we anticipate a consolidated loss of almost $22.8 million. I will say the budget provides for an increase in EBITDA of about $5.5 million to the 50.1 we've mentioned, and on a consolidated basis, it's providing for an increase in EBITDA of about $4.5 million to $29,176,000. So with that, I'm going to invite Dan Nardoni to the podium to get into the details of all these numbers.
Good evening, and thank you, Chris. I just wanted to start with thanking Nancy and Chris for this opportunity to present the 2020 budget, along with thanking them for their leadership during this process. I also, as Chris had mentioned, wanted to thank our management team for all of their hard work, as this took many, many hours to put together, and it was a very difficult budget this year. And of course, my right-hand person, Erica Nelson, that Chris had mentioned. Okay, so let's get into the numbers tonight. As Nancy had mentioned, one of the big external factors that we were faced in creating this budget was CMS's desire to really cut expenses. And this manifests itself so clearly in that mandate to force joint replacement cases to the outpatient setting. You know, as CMS continues these cuts, we in turn have to be driven to find more areas where we can improve net revenue. We plan to accomplish this by putting significant effort into expanding some of our product lines, including joint replacement, cardiac surgery, oncology, neurosciences, and obstetrics. You know, while we may not have budgeted major improvements in volume in some of these product lines, these will be the areas of focus for 2020. Okay, so taking a look at our admissions. Admissions for this next year are expected at 11,726, a reduction of about 1.4%. Again, that is that transition of joint replacement cases going to the outpatient setting. This really started in earnest back in about September of this last year, and so this represents a full year of that transition. These are being offset by increases in our cardiac surgeries, general surgeries, and some of our peripheral vascular procedures in the cath lab. Patient days are anticipated to decrease just slightly, giving us an average daily census of 163. This reduction, again, reflective of that shift in joint replacement cases, offset by the surgical and procedural volume that I mentioned. Outpatient observation days of 1,893 are expected to remain consistent with what we've experienced this year. And our average length of stay is expected to rise just slightly to about 5.07 due to the changes in admissions, and particularly the increase in cardiac surgeries, as these tend to have a much longer length of stay. Deliveries of 1,540 are anticipated to remain consistent with fiscal year 19. As I mentioned, though, this is an area of focus for us in this next year. Surgical cases are expected to increase about 1.1% to 4,587. Within this total, joint replacement cases are expected to remain consistent at 1,744, with almost half of those now being done on the outpatient side. Cardiac surgical cases are expected to increase to 125 as our relationship with UCSF providing cardiac surgical services continues. You know, this increase is really related to valve cases as we prepare ourselves to perform more minimally invasive valve surgeries in the future. Neurosurgical cases are anticipated to remain consistent with fiscal year 19 at 293, while our generalist surgeries are expected to increase to 2,425, which kind of follows the current trend that we've been experiencing over this year. Cath lab procedures are expected to increase to 4,203. We're anticipating slight increases in our peripheral vascular procedures along with our non-vascular interventional radiology procedures, while our neurointerventional radiology procedures and cardiac procedures are expected to remain consistent with 2019. Emergency room visits of 50,834 are anticipated to remain consistent with our current experience, while our non-emergency outpatient visits are increasing slightly. This is being driven in large part due to our continued success and growth of the prenatal diagnostic clinic. We will also have a slight increase for outpatient lab as we have watched that volume grow in this area for the last year. Okay, moving on to our performance indicators. Total paid FTEs are expected at 1,480.7. This includes an increase in FTEs for volume coupled with the related FTEs needed to staff the Morris Hyman Critical Care Pavilion for the year. This was offset by reductions achieved through identifying operational efficiencies. Okay, our paid FTEs per adjusted occupied bed are anticipated at 6.33, and our productive FTEs per adjusted occupied bed at 5.52. All right, taking a look at our volume trends. Admission trends, as you can see here from 2018 to 2020, this is a large visual of the significant shift of patients that CMS is moving from inpatient to outpatient. Looking at admissions by payer, we're not anticipating any major changes in our payer mix for this next year. However, this is a picture of that smaller base of inpatients from which we can attempt to recover the shortfall of the government payments that Chris has mentioned earlier. Patient days are decreasing slightly from 2019 to 2020 as a result, again, of that shift in joint replacement cases and being offset by the increases in surgeries and procedures. Deliveries, you can see that the trend here in the deliveries from 2018 to 2019, this is really brings to light it's more of a national phenomenon than a change in our service area as birth rates continue to drop. We believe, though, that our growth in the prenatal diagnostic clinic with more high pregnancies will be able to be delivered here at Washington Hospital, which will stem the downward trend that we've experienced in deliveries. Total surgical cases continue to rise, coming up to 4,587. Again, this growth is anticipated in our cardiac and general surgery programs. And the increase you see here from 2018 to 2019 is really reflective of that general surgery program increase that I was talking about. Looking at our cath lab procedures, increasing just slightly this year to 4,203. And again, that increase really in our peripheral vascular and non-vascular interventional radiology procedures. And again, our emergency room visits are anticipated to remain consistent with the visits we've experienced in this fiscal year. And our outpatient visits growing just slightly up to 89,722, again, due to the continued growth of the prenatal diagnostic clinic and some of our outpatient labs. Okay, starting to look at the financials. Gross patient service revenue is projected to increase $16.4 million, or about 0.7%. This increase reflects the increased volume we are projecting for next year, and then coming in at about $2.1 billion. Contractual allowances estimated at about 75.2% of gross revenue. The decrease from 75.9% is really due to some favorable changes in some of our contracts with our commercial payers. And the provisions for charity and doubtful accounts is increasing $367,000 due to the increase in volume and related gross revenue. We've budgeted this provision consistent with fiscal year 19 at about 2.4% of gross revenue. Last year this percentage was about 2.1%. But however, due to the volatility of some of the federal and state legislative acts that Chris has talked about, it's really difficult to predict where this may land. So we're maintaining our current experience. Okay, looking at other operating revenue, cafeteria and health education revenue is anticipated to remain consistent with 2019, while we do expect an increase in our outpatient services revenue of about $100,000, and this really relates to lab services, which are where we are increasing, providing more lab processing to outside organizations. Prime project funding is expected to drop about $765,000 this year. As you may recall, we are participating in the Public Hospital Redesign and Incentives Medi-Cal program called Prime under the Medi-Cal 2020 waiver. The two projects we have in this program are our prenatal diagnostic clinic and our palliative care program. Prime provides startup funds and performance-based funding for these programs, and the reduction in funds were really expected for years 4 and 5 of this 5-year program. And we are starting in fiscal year 20 into year 5 of the program. And talks for the next 5 years of Prime have just begun. Looking at our other revenue, in fiscal year 2019, the Fundraising Foundation was able to donate $2.7 million to the hospital for the Morris Hyman Critical Care Pavilion and for other hospital programs. In fiscal year 20, the foundation anticipates donating approximately $1.3 million. We are also anticipating a reduction of approximately $350,000 in our bundled payments from Medicare for participation in the joint replacement program. So this is a result of our joint replacement surgeries moving to the outpatient setting, as this program really only takes into account the inpatient cases in that program. So you can see here that how this transitions again aided CMS in cutting costs. Okay, moving to our operating expenses. The base of our operating expenses is budgeted, as Nancy and Chris have mentioned, by taking a zero-based approach to our expenses that are not driven by volume, and we ask our managers to justify the resources they need each year. The salaries are expected to increase $5.4 million. This is mainly due to wage inflation of between $1.5 and $3 million on our current contracts and market adjustments, and a full year of the additional positions needed for the Morris Hyman Critical Care Pavilion. Benefits are budgeted to increase about $3.97 million. Inside this increase is an increase in health and welfare benefits of about 6.6% and an increase in payroll taxes on the increase in salaries and wages. Professional fees are expected to increase about $1.3 million this next year. This increase is primarily due to additional costs related to the market-based adjustments of our hospital-based physician programs. This was offset by various reductions in consulting and legal fees. Supplies are anticipated to decrease by 1.5%. This includes an increase in cost for the additional volume and a 3% inflation factor for medical supplies and an 8% inflation factor for pharmaceuticals. This is being offset by negotiated pricing reductions in various areas. Year after year, this pharmacy inflation continues to outpace medical supply inflation 2 to 1. Purchase services are expected to come down about 4.8%, and this is really centered around the district not having to underwrite the cost of a board election this year, as they happen every other year. Utilities are going up 5.5%, and this is reflective of a full year of operation of the Morris Hyman Critical Care Pavilion and some inflation. Insurance costs are going up 16.2%. And this includes a slight increase in volume, which affects our professional liability insurance, but also includes a 26% increase in our property insurance premiums. This increase is in large part due to the insurance companies trying to recoup some of those losses from those catastrophic wildfires and floods on the East Coast this past year. Marketing and advertising expenses is expected to remain fairly consistent with 2019, and our software license and maintenance expenses are expected to increase by about 5.9%. This line continues to grow each year as IT becomes a bigger part of our patient care. Other expenses are decreasing about $1.2 million in fiscal year 20, and this is due to the resolution of some legal matters in fiscal year 19 and the move of our diabetes clinic and our maternal child health clinic to on-site locations. All right, and then depreciation, as Chris and Nancy have pointed out, going up about almost $7.6 million in 2020 as we take on a full year of depreciation for the Morris Hyman Critical Care Pavilion. And this increase also includes new projects, equipment, and anticipated for this next year, and a full year of depreciation for related to projects that have recently been completed. And as Chris had mentioned, I just want to remind you that depreciation is a non-cash expense where we recognize cash already spent over the life of the purchase of the assets. So taking a look at the operating expense summary, we can see that depreciation is making up almost half of the change in our operating expenses over fiscal year 19. And if we step back even further and look at depreciation and labor costs, those are truly making up the entire increase in our operating expenses for fiscal year 20. In fact, I would say that those expenses aside, our operating expenses are actually dropping $1 million for next year. All right, and then taking a look at our our operating expense trend. So one of the things I wanted to do here was point out to you this bottom section of the graph here. You know, management has done a great job of controlling these expenses over the years. But you can see here on this red line, which is our depreciation line. As the CJR and the power plant came online, our depreciation came up. And then again here, as we come here, we can see that the Morris Hyman Pavilion has also brought that line up. But the overarching increase in our expense profile is really labor. And you know, with the tight labor market we have here in the Bay Area, it makes it very difficult to recruit and maintain top talent. And so this line is really a huge factor in this total operating expense line. And you can see here that over time, our total revenue line and our total operating expense line have come together. And that's why we're talking about the fact that we need to get the trajectory of that total operating revenue line back up above that total expense line again. And so the focus on those product lines and expansion is truly paramount to success for us here. Okay, another look at our operating expense distribution. Again, salaries and wages making up 62% of our total cost profile, followed by pro fees and purchase services at 12%, supplies as well at 12%, depreciation at 10%, and other expenses at 4%. And then for the good news that's been mentioned tonight, our earnings before interest, taxes, depreciation, and amortization expected at $50.1 million this year, which is really a 12.2% increase over the projected for fiscal year 2019. You know, a lot of this is due to our net revenue is actually outpacing our operating expenses less depreciation that caused this. You know, this is a sign that despite the increase in depreciation, the operations of the hospital are still strong in generating good cash flow. Okay, and looking at our non-operating income and expenses, investing income is expected to remain consistent with fiscal year 2019 as the volatility in the interest rates at this time make it difficult to predict something other than that. General obligation property tax revenue coming down about 2% this year. That represents the pay down of principal over time, as well as the recent refinancing of some of our general obligation bonds. Now, this revenue is collected to pay the debt service on those general obligation bonds, and the reduction in this is really good news for our district residents. Bond interest expense is going up 38.7% this year, and as Chris had talked about, that really reflects the accounting change that we've had to adopt with the interest expense no longer being capitalized, but coming straight to our income statement. Bond issuance costs are coming down this year, about 28.7%. In 2019, we had done 2 bond refinancings, and for 2020, we're anticipating doing 1 bond refinancing of our 2010 revenue bonds. Rental income revenue is coming down about 12.7%, and this reflects 2 spaces within our Fremont Office Center that we've are holding as we were planning to transition to WTMF clinics in the future. Amortization of intangible assets is going away this year. That was an accounting entry based on our acquisition of the Fremont Office Center and the leases that we had at that time. That amortization ended in April of this year, so won't be going forward. The Morris Hyman Critical Care Pavilion move, and it was a one-time cost based on that activity. And as you know, we don't budget for realized gains and losses or unrealized gains and losses on our investments. It's just too difficult to predict the swings in the market. Looking at our capital projections, we anticipate new capital requests of about $7.8 million this year. This is a list of some of the anticipated projects that we will bring forward for approval during the year. As on the facility side, you can see several remodel projects. And on the IT side, Alaris Epic integration, along with some Microsoft upgrades. And then looking at the equipment that we'll be bringing forward, we'll include the Welch Allen monitor replacement of Phase 2, the 3D mammography system, some capital for the Fremont Office Center, our computer, copier, and communications refresh budget, along with the Bruker-Malditoff bacteria identifier. So all this giving us total projects of about almost $3.7 million and total equipment of $4.1 million for a total of $7.8 million this year. We do anticipate continued spending on previously approved projects of about $1.8 million. And with that, this is our 2020 budget presentation. Any questions?
Do we have any questions from the board? Apparently not.
Great.
Chris, and we really appreciate the presentation. Well done. Very, very comprehensive. Very nice to get all that information together. Tremendous challenge. And we appreciate all the work that you've done and all the work that the staff's done. Very, very impressive work. We'll see how it turns out, huh?
I just wanted to say that for those folks that don't really get this depreciation expense, I think it's something that it's not easy to grasp, but because it's an esoteric accounting mechanism, which basically is saying, well, you spent hundreds of millions of dollars building the Morris Hyman Pavilion, and that is when the cash went out. And as you use the facilities, they depreciate, and the concept might be that, well, they're actually wearing out. What has happened is that the accounting profession has said, okay, this building is going to last 40 years. And so what we have experienced so far is that existing facilities have been around 60 years, and they're still there, and they're not gone anywhere. And from an accounting point of view, they were fully depreciated. So from looking at our financial statements over the last 20 years, we didn't have any depreciation because those things were fully depreciated. And so now you have a change where you have not recognized any depreciation, building's still there, no depreciation expense. We have new facilities, and now we are incurring a non-cash depreciation expense of nearly $50 million a year, which in reality, even though we say that the bottom line of the organization is $22 million negative from a profit and loss standpoint in the coming fiscal year, in reality, from a cash business aspect, you add the $50 million to that $22 million loss, and presto changeo, the organization has created $28 million of new cash to spend on whatever the heck we need to spend it on in the coming fiscal year. So, no one should be too alarmed about the basic bottom line being negative, because of the fact that most of that negativity is brought on by an accounting treatment for the depreciation expense. So,
I appreciate that.
thank you. Thank you.
Personally, I've wrestled with that concept,
Yeah.
and I appreciate the explanation of that.
Yeah.
In the past, we've taken a little bit out of order with our agenda tonight to actually bring up the approval of that budget that we've just been presented. So I'd like to have Dr. Nicholson present that motion at this point in time.
Mr. President, item A. I move for adoption of resolution number 1198, which is the budget estimate for fiscal year 2019-2020. This resolution provides for the necessary funds required for the operation of the district and for the continued support of the Washington Township Hospital Development Corporation in its operations to promote the charitable and community service mission of the district.
Thank you. Do we have a second on that?
Second.
And any discussion? I just repeat, brother, we really appreciate your work. That is a tremendous accomplishment, I think. So Dee, if you'd take the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Epen.
Aye.
Director Yee.
Motion passes. Thank you. Thank you. It's a wonderful thing. We'll now talk about the future also. And Nancy, if you could introduce our strategic map presentation.
I'd be happy to. Presenting our strategic map this evening is Donald Pipkin. He's been with our hospital since 2006 and is our Chief of Strategic Management. He received his Bachelor of Arts degree from Claremont McKenna College, where he majored in environment, economics, and politics with a leadership sequence, and received his Master of Healthcare Administration degree from the University of Washington in Seattle. He works closely with our Kaizen promotion office to implement our Toyota production system at Washington, and he is a Lean certified workshop leader.
Thank you, Nancy. Good evening. So it's been a few years since we presented our previous strategic map, which was through fiscal year 2016 through 2019. And we've recently updated the strategic map, and tonight we'll be presenting it to you for your consideration. I will briefly touch on some of the external environment highlights. You heard a number of them from Nancy, Chris, and Dan. I'll also highlight some of the district's core values and how we incorporate those into the strategic planning process. We'll walk through what are the components of a strategic map as it depicts a strategic plan, and then finally we'll provide a summarized version of that strategic map for your consideration. So as you heard, there's a lot of uncertainty both at the state and federal level in terms of what we will see in terms of pending regulations and legislation that can impact the healthcare district and our operations. But we know there are some trends that we can likely expect over the coming years. We've heard the downward pressure on revenue and reimbursements coupled with an increase in cost, both from staff and labor costs, but also through unfunded mandates such as seismic regulations, pharmaceutical price increases, and also some of the state legislation, and I think the homeless bill is a good example of that. So in general, we expect those trends to continue, and as I think Dan's graph showed, that intersection of the expense and the revenue lines, we do expect those expense lines to continue to increase. However, in that environment, the district has a set of core values that we've adhered to, not only in our operations, but in how we develop strategic plans as well. We are committed to our shareholders, our owners, the district residents, and remaining an independent healthcare district to serve the district. We believe in providing appropriate care in the least costly environment possible, and also developing that inpatient volume replacement as we see that shift to outpatient occur. Survival through a system. So it's not just the acute care inpatient services we provide, but it's also the ambulatory services, both potentially pre-admission, post-discharge, and also through the fantastic physicians in our medical foundation. Key is also forming strategic alliances with, an example is our key partner UCSF, to build and strengthen those programs and the services in the district. And tied to that is a concept of moving doctors, not patients. It's bringing those tertiary or quaternary or super specialized services into the district so residents can access them here without having to travel outside the area. And it's really been under the direction of our board of directors that we've been committed to these core values. The board has had the foresight and the wisdom and the vision, along with the leadership team and our CEO, Nancy Farber, to successfully guide that healthcare system through many challenges facing the industry. That commitment is demonstrated not just through the initiatives we've implemented and developed, but also in how we plan for the future as well. And again, this is just a brief example of some of those key initiatives and programs. The big one is the opening of the state-of-the-art Morris Hyman Critical Care Pavilion on time and on budget. We've also partnered with UCSF to bring their faculty to provide cancer care in the UCSF Washington Cancer Center. And we also have UCSF faculty providing care in the Prenatal Diagnostic Center. We also continue to integrate Lean into our operations to advance our initiative of remaining that high-quality, low-cost provider of choice. And we also continue to focus on the growth of the medical foundation as well. And as also been mentioned, meanwhile, we continue to receive a number of recognitions for our high-quality care. Health Grades, one of the top 100 hospitals in the nation, distinguished awards for clinical excellence. U.S. News and World Report named Washington one of the best regional hospitals in the San Francisco Bay Area, and baby-friendly designation provided by the World Health Organization and the United Nations Children's Fund. So we continue to provide very high-quality services as we continue to expand them. So in strategic planning, we use a concept called strategic mapping. This is our fiscal year 2020 to 2022 strategic map. What it is really a one-page graphic depiction of the key elements of our plan. It focuses on a central challenge that faces the healthcare system over the next 3 years. It outlines those key strategic priorities that support that central challenge, and also the key objectives we'll have to achieve over those 3 years to meet that central challenge. So I'll walk you through the components of a strategic map and then finally provide a summary of that as well. So the central challenge facing the healthcare system is to position Washington Hospital Healthcare System as the healthcare system of choice for a number of stakeholders: patients, providers, staff, district residents, and all payers. Supporting that central challenge are 5 strategic priorities. A is to drive growth and prioritize service lines and targeted markets. This really gets to the concept of that inpatient volume replacement and focusing on the key areas that we need to focus on to grow volume. B, expanding and strengthening provider relationships, whether they're in the foundation, independent community physicians, or third-party providers for post-discharge care as well. C is expanding and deepening community awareness and engagement. This is about educating our residents about the district and the services we provide. D is increasing financial strength and sustainability. This really is focused on the operations and the finances of those operations, whether it's maximizing the use of the data that we have or optimizing services. And finally, to strengthen the capabilities to drive future success and differentiation. So this comes back into facility master planning, staff, IT capabilities, etc. At the bottom of the map are what we call cross-cutting priorities. These are at the bottom because they really are foundational to the strategic plan. They also span from left to right because any initiative taken to address one of the strategic objectives needs to take into consideration the strategic priorities. So we have implement mission-critical technology to enhance the patient experience. This could be how a patient accesses, say, our registration system to medical technology we're using in the facility. Strengthening and expanding our alliances and partnerships across that continuum of care, whether it's pre-admission, post-discharge, or with our partner UCSF. And then also continuing to drive continuous improvements in quality, value, safety, and the patient experience as well. So those are the basic components of a strategic map. Within each of the strategic priorities are strategic objectives. These are those items that we really have to put significant resources and effort into over the next 3 years to achieve those priorities to meet that central challenge. And this is a summarized version of our strategic map for your consideration. I'll point out just a couple of the items on here. Item A, that first bullet point, implement growth strategies for key service lines. Some of those Dan mentioned as well. And we've also heard from our residents the importance of a trauma center. There is not a trauma center in southern Alameda County. So it's really doing the due diligence and planning to pursue that designation and the funding for that trauma center. Under column B, continuing to expand our medical foundation, both in terms of the mix of specialties and the number of providers, but also working with independent physicians and also with those services across the continuum of care, for example, post-discharge and working with skilled nursing facilities in the community. Under column C, continuing to educate our district residents and owners about the unique value of having a high-quality district hospital that is committed to serving their needs. Under D, implementing operational and financial metrics to optimize value and reduce cost. We have a lot of data. It's about making that data as timely as possible and as actionable as possible. And then under E, of course, the next phase of the facilities master plan in consideration of the seismic regulations and also focusing on that recruiting and retention of staff that provide excellent care to our patients. So that's a summary of our fiscal year 2020 to 22 strategic map for your consideration. And with that, I can answer any questions if you have them.
I'd like to say that many people that may be here or watching this on TV might find it quite unusual for an organization to share its strategic objectives with the community, but more importantly, with the competitors to the organization. And I think this underscores the fact that we are dedicated to the community. We want the community to know this is what we're up to, this is where we're going, this is what we're going to do. And we don't care whether the competitors know about it or not.
Absolutely.
So thank you for the work that you've been doing in creating the strategic plan.
Absolutely. Thank you.
Any other comments? Thank you
Thank
very
you.
much, Don. It's always nice to have that laid out. I think we've heard several times tonight the importance of serving the residents of the district. Our prime directive is to provide health care and all other services to our communities, and our plan shows that. We don't care about the competitors, we'll beat them anyway, right?
You want to take a motion?
Yes. Dr. Nicholson.
Mr. President, item B, in accordance with district law, policies, and procedures, I move that the Board of Directors approve and adopt the Washington Hospital Healthcare System Strategic Map for fiscal year 2020 through 2022, which depicts the key elements of Washington's 3-year strategy with the understanding that adjustments may need to be made as the environment changes.
Thank you. Do we have a second on that?
Second.
We have a motion and a second. Any further discussion on that item? D, if you take the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Eapen.
Aye.
Director Yee.
Aye.
That motion passes. Now we can return to our normal agenda, which is our consideration of minutes for May 3, 7, 8, 20, 22, 28, 2019.
Mr. President, I move for approval of those minutes as enumerated.
And do we have a second?
Second.
And we have a motion and a second on that item. D, if you take a roll on that.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Eapen.
Aye.
Director Yee.
Aye.
Motion passes. I think it's indicative of that motion that show you how the work the board's been doing this last little while. At any rate, are there any oral communications this evening? Seeing none, we'll move to our written communications, and Dr. Achanta is with us tonight. Welcome. Good to see you. If you'll present the action items from the medical
Credentials.
staff.
It's a pleasure to be here again. Thank you for the opportunity. These are the following credential items for this month. We have 5 new physicians, physicians and allied health professionals. I stand corrected. Moisur Anwar, MD, Radiation Oncology, Provisional Active. Amber Chen, Nurse Practitioner, Emergency Department, Allied Health Professional. Rachna Krishnan, MD, OBGYN, joining PAMF, Provisional Active. And Sunil Kumar Taghali, Internal Medicine Sound Physician, joining as a Provisional Active. All 4 of them are also requesting temporary privileges, awaiting board action. Dr. Moisur Anwar is also requesting locum tenens coverage during this time for radiation oncology. Reappointments for 2 years. Aruna Chakravarti, MD, Medicine and Endocrinology. Gurleen Dio, PA in Surgery. Craig Johnson, MD in OBGYN. Christina Lee, MD, Internal Medicine. Ronald Matsuzak, Internal Medicine and Hospitalist. Jasbir Jenny Multani, MD, Surgery and Neurosurgery. Doris Nguyen, MD, Internal Medicine. Deepti Saxena, MD, Family Medicine. Alana Shane, MD, Pathology. Rajesh Singhal, Surgery, Urology. And Manish Singhal, MD, Internal Medicine. And Sunil Upinder, MD, Radiology. For reappointments for 1 year, Dr. Jeffrey Carlson, Medicine and Cardiology. Dr. Pradeep Kumar, MD, MD and Interventional Cardiology. Dr. Gopala Koluru, Medicine and Cardiology. And Dr. Eric Okimoto, Plastic Surgery. Transfer of staff category, we have Juan Ha, MD in Hematology Oncology, moving from Provisional Active to Active. Dr. Joshua Lin, DO, Internal Medicine Hospitalist, moving from Provisional Active to Active. Dr. Jenny Multani, Surgery and Neurosurgery, moving from active to Courtesy. And Dr. Imran Siddiqui, Internal Medicine, moving from Provisional Active to Active. Completion of proctorship prior to eligibility for advancement. Dr. Shrikant Ambati, Internal Medicine. Garima Gandir, DO, Internal Medicine. Kwa Mint, Internal Medicine Hospitalist. Yashahiro Oki, Medicine and Hematology Oncology. And Almerio Yanga, Internal Medicine Hospitalist. All have completed proctorship but cannot be advanced to the active status yet. Completion of proctorship and advancement of staff category. Dr. Juan Ha, Internal Medicine, moving from Provisional Active to Active. Dr. Joshua Lin, Internal Medicine Hospitalist, moving from Provisional Active to Active. Dr. Imran Siddiqui, Internal Medicine Hospitalist, moving from Provisional Active to Active. And Dr. Richard Cuentas, Radiology, Nurse Practitioner. Finally, we have extension of proctorship. Dr. Namrita Boparai, Internal Medicine, is remaining in Provisional Active status while she awaits completion of proctorship. Deletion of privileges. Dr. Jeffrey Carlson has opted to delete the privileges listed. Dr. Jenny Multani is giving up gamma knife privileges, gamma knife treatment planning, and moderate sedation. And Dr. Deepti Saxena is giving up ICU level 2 and level 3. Dr. Pradeep Kumar, Internal Medicine and Cardiology, has declared the following conflict of interest with ownership in sleep diagnostics of Fremont. We don't have any leave of absence, reinstatement of leave of absence. We've had withdrawal of applications. 2 applicants withdrew their applications while under process. Dr. Conveyor Gill, gastroenterology, and Dr. Camelot Thompson Camelot Thompson, nurse practitioner for ED. We have one resignation, Dr. Michael Bastash, resigning from radiation oncology.
Thank you very much.
You're welcome.
You did that like you've done it before. Anyway, thank you. Do I have a motion on those items? And a second?
Second.
So, Dee, if you take the roll on that.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Wallace,
Aye.
Director Epen,
Aye.
Director Yee.
Aye.
Good, that motion is accepted, passed. Good to have that done. We'll now have our Service League report from Ruth. It's good to see you this evening too, Ruth.
Nice to see you. Good evening. So tonight we're just going to mention two things that I had looked over or had come my way since our last meeting. So first of all, we're the Volunteer to Service League Department. And I saw an article that was written by CNN, and it talked about the generosity of volunteerism in America. And so just to know that our facility really promotes volunteerism is good to know that we're in line with what is happening in the state of our country of America. It says Generation X tends to have the most hours out there. And in the last year they did the census, it was 77.4 million Americans volunteered 6.9 billion hours in a year. So it lets you know that volunteerism is a high note in America. And to go along with that, in the last information session that the Volunteer Services Department had, we had over 100 students that came and signed up to be volunteers. So next week in our orientation session, we have 80 confirmed new volunteers that we will be setting up and getting them ready to start training. So that is the largest information session and upcoming orientation session that I understand the hospital has had in some years. So we're happy to see that number of volunteers coming in. And along with that, we 10 adults who had came in with their student decided to just sign up to be volunteers. So we're always happy to have the adults signing up as well. So out of that, we got 10 new adult volunteers. The other thing that we're really, really excited about, and we'll have more information for you on next month, is our pet therapy program is moving along really well. We have had our first patient visit with Team Weinberg, and it was well received. We had the nurses hugging the pets. Just a tremendous outpouring of acceptance of this new service that the hospital is offering. We had one nurse who informed the handler, Russ, that her patient had not smiled or had a very positive response since they had been there. And after having a visit by the pet therapy team, the patient was just uplifted and just very happy. So we anticipate seeing a great demand for the pet therapy program, and we have a couple teams coming on. We'll have Team Farber once we have a retired CEO, and we have another team, this Team Margalis, and her animal is called Apple. So we're very excited, and we will be posting pictures and giving you more information as the education continues for staff as well. So we're very excited for the new program. Any questions?
I don't think so. Thank you, Ruth. It's always nice to know of the good things that are happening in the Service League.
Thank you.
It's exciting.
That was exciting.
Nancy, if we could now move to our hospital calendar.
I have one more report.
Oh, I'm sorry. How did I turned the page too soon.
That's okay.
Apologize.
Dr. Stewart and the board, I'm glad to report that the medical staff numbers are strong. We are above 600 strong. We have 361 active staff members, 3 in administrative positions, 27 allied health professionals. We have 103 in the ambulatory setting, 7 in the consulting arena, and 25 courtesy physicians and allied health professionals. We have 2 in leave of absence. We have 54 provisional active members on medical staff and 10 in the allied health professional. We have provisional consulting in 3 and provisional courtesy 3. Temporary privileges for 4 physicians and allied health professionals for a total of 602. So I think we are in good hands.
So this is the first
It
clear
is.
600?
Yes. I came close to 600 during my term, but looks
well.
like Tim made it over.
Yeah,
You got to announce it.
but you got to announce it, yeah.
Yes.
It'll be your responsibility to keep it above 6.
It'll be the next teams.
Anyway, thank you very much. I'm not sure the public is all totally aware of that, but the medical staff has been bouncing up against 600 for a long, long time. And even though it's 602, we'll take it. Anyway, thank you. Now we can move on to the hospital report.
We'll start with the video on the calendar.
Past health promotions and outreach events. On Thursday, May 9th, the Washington Hospital Green Team hosted an Energizer station as part of the National Bike to Work Day. The team greeted cyclists with goodie bags, fresh food, water, and pastries during the morning commute at the Fremont BART station. More than 100 cyclists participated. Also on Thursday, May 9th, Washington Hospital hosted Celebration of Life. This event featured stories of survival and hope for cancer survivors and their families. In addition, Dr. David Lee, hematologist-oncologist, presented strategies to help reduce the risk of cancer. Dr. Victoria Leapart, gynecologist, provided the welcome address and moderated the event. The event was co-sponsored by Washington Hospital, HERS Breast Cancer Foundation, UCSF Washington Cancer Center, the American Cancer Society, Ambry Genetics, and the Tri-City Voice. 63 people attended. On Thursday, May 16th, as part of the Women Empowering Women series, Dr. Victoria Leapart presented Bad to the Bone, Understanding Osteoporosis. 13 people attended. On June 1st and 2nd, the American Cancer Society hosted the Tri-City Fun Relay for Life event at Newark Community Center Park. This 24-hour walkathon raised money and awareness to save lives from cancer. Washington Hospital and Washington Township Medical Foundation were major sponsors. The Tri-City Fun Relay for Life team raised $180,000. More than 500 people participated. On Sunday, June 2nd, Washington Hospital staff provided health information at the Be Your Own Hero Bicycle Treasure Hunt event hosted by Boldly Me. The event aimed at raising mental health awareness. More than 50 people attended the event. On Tuesday, June 4th, Dr. Jason Chu, pulmonologist and medical director of Respiratory Care Services, presented Wildfire Smoke and Your Lungs. Do you need to worry? 17 people attended. Upcoming health promotions and community outreach events. On Thursday, June 13th, from 6 to 8 p.m. at the Washington Township Medical Foundation Newark Clinic Conference Room, Dr. Victoria Leapart will present Vitamins and Supplements. How useful are they? On Thursday, June 20th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart will present Throw on your athletic shoes and let's get moving. This special presentation includes a half-mile walk to Shin Historic Park, where participants will practice Tai Chi before returning to Washington West. Bay Area Healthier Together. Washington Hospital's partnership with ABC7 continues to provide health-related information and education through on-air programming and on BayAreaHealthierTogether.com. The featured topic during the month of May was stroke awareness, featuring co-medical directors Dr. Prabjot Khalsa, neurologist, and Dr. Jack Rose, neurointensivist of the stroke program at Washington Hospital, plus articles on stroke response time and understanding the different types of stroke. The Washington Hospital Healthcare Foundation Report. On Saturday, October 12th, the Washington Hospital Healthcare Foundation will host the 33rd Annual Top Hat Dinner Dance. The trustees of the foundation have designated the proceeds from this year's Top Hat Gala towards the support of the Washington Hospital Women's Center with the purchase of 3D mammography equipment. This cutting-edge technology has been proven to produce clearer diagnostic images, making it easier for physicians to detect abnormalities and reducing instances of false positives and unnecessary biopsies. To reserve seats at Top Hat or to inquire about sponsorship opportunities, please call the Foundation at 510-818-7350. During the annual scholarship luncheon hosted by the New Haven Schools Foundation on May 22nd, Washington Hospital Healthcare Foundation presented scholarships to 2 graduating seniors from James Logan High School. Galen Hamilton, Chief Operating Officer of Washington Township Medical Foundation and member of the Board of Directors of the New Haven Schools Foundation, presented the scholarships on behalf of the hospital. The recipients of the scholarships were Jennifer Diaz and Margarita Garcia. Jennifer will enter Cal State East Bay in the fall and plans to study nursing. She is currently a volunteer in the Washington Hospital Service League, and Margarita plans to attend San Francisco State University in the fall and would like to study healthcare administration. The foundation received a thoughtful and generous donation of stuffed animals from 2 Washington High School students. Inspired by the Do Something project, which encourages high school students to support their community, these students held a stuffed animal drive collecting more than 40 stuffed animals, which were donated to the emergency department and pediatric unit. 3 special 6th graders from Maloney Elementary School in Fremont recently completed a community service project in support of patients being cared for at our UCSF Washington Cancer Center. Through bake sales, the students raised funds to create 47 care packages for patients undergoing cancer treatments, such as chemotherapy infusions. These packets included items such as lip balm, puzzle books, sleep masks, and hard candies. The Washington Township Healthcare District Board of Directors report. Washington Township Healthcare District Board members attended Indo-Americans for Better Communities Charity Ball on May 11th. Washington Hospital Employee Association, WIA. In May, WIA held its annual wish list event in which various hospital departments submit non-budgeted requests for patient care items. WIA awarded $14,847 for items such as a wheelchair for outpatient rehab and hospital-grade temporal thermometers for the CCU. Washington on Wheels, WOW Mobile Health Clinic. The Washington on Wheels Mobile Health Clinic, WOW, is a mobile medical unit providing quality healthcare services primarily to uninsured and underserved district residents. WOW brings Washington Hospital's commitment to patient-first care to clients throughout the district. During the month of May, WOW served community members at the following locations. In Fremont, the Family Resource Center, Bay Area Community Services, BACS, TCV Food Bank and Thrift Store, and the Irvington Presbyterian Church. In Union City, the Ruggieri Senior Center, Alvarado Resource Center, Union City Family Center, and Our Lady of the Rosary Church. In Newark, the Viola Blythe Community Services Center and the Salvation Army. These community partners provide social services to families in need and the homeless population. WOW also provided healthcare services at Materion, a material solutions company in Fremont. The total number of community members receiving healthcare from the Washington on Wheels Mobile Health Clinic during the month of May was 153. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The hospital's employment section was May's most viewed webpage with 33,190 views. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a news feed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of May, Washington Hospital's cable channel 78, InHealth, captured new programming, including 2 health and wellness programs titled Endometriosis, Causes, Symptoms, Diagnosis, and Treatment, and Gastrointestinal Disorders. In addition, InHealth aired a health and wellness program titled Metabolic Disorders, a Diabetes Matters program on diabetes and kidney health, and the May Board of Directors meeting. Awards and recognitions. Washington Hospital proudly announced 4 recipients of the Nurse of the Year Award. They are Darcy Alley, RN, William Christabel, MSN, RN, CEN, Heather Garcia, RN, and Dexter Hermasura, BSN, RN, BC. Recipients of the Nurse of the Year Award are nominated by their managers for exemplary clinical skills, leadership, and professionalism, as well as dedication to the hospital's mission and patient-first ethic. 4 deserving nurses are then selected from the nominees to receive the award by the hospital's Medical Executive Committee. For more information on any of the programs mentioned, visit whhs.com or call 800-963-7070, and please follow us on Facebook, Twitter, Instagram, and YouTube.
And now it's my pleasure to introduce the June Employee of the Month to all of you. Her name is Menchu Cruz. She's a staff nurse 3 on our observation unit on 3 North. Like many of the care providers at Washington Hospital, Menchu felt the calling to help others at a young age. She says, "The more I learned about science and medicine, the more I wanted to be part of a healing team." She began her nursing journey in the Philippines. She was in nursing school when her father, who had previously immigrated to the United States, let her know that she was approved to join him here. In order to join her father, she had to give up nursing school in the Philippines and start all over again when she relocated, which is what she did. But when she got here, she discovered the nursing schools were heavily impacted, and she decided to take courses on phlebotomy and began an internship here at Washington Hospital in 1997 as a phlebotomist. Her talent and her work ethic were immediately recognized by leadership, and she was offered a full-time position once she completed her coursework. She enjoyed the work and the family-like environment, but she certainly had not given up on her dream to become a nurse. Once her application to nursing school was accepted, she was grateful that her managers encouraged her to adjust her work schedule to allow her to be a full-time nursing student. Soon after she graduated from nursing school, she was offered a job, and from that day on, Menchu has called Washington Hospital her home. She earned her BSN while working full-time. When the observation unit was created in 2017, she was one of the original staff members on that unit. She plays a critical role in coordinating different departments to ensure that needed tests are completed and the appropriate physician has the results to assess the patient's condition. She's somebody who embraces our patient-first ethic wholeheartedly. She believes that every patient should be treated as a beloved family member. In her case, she feels she's caring for her mom with every patient. Could not ask for more. Family is important to Menchu. She's one of 5 children, and she and her siblings are all local, which is wonderful to have the family together. And most weeks get together for Sunday dinners. She and her 2 sisters took a trip to Europe recently, visiting Paris and Rome. Somewhat like the journey of her career, the trip was a dream come true. We're very proud to have her working here with us.
Thank you, Nancy. What a wonderful story.
It is a wonderful story.
That's really, really fun to hear. Well, now I'd like to have our lien report. Kimberly Hartz will present that.
It is my pleasure tonight to recognize one of the physicians who is here, who is going to receive his Lean Leadership certification. And as we know, we started our lean journey in 2014. Really, this is an initiative that was something Nancy Farber had brought forward to us, to this organization. And it's really been her leadership and her vision that has really led this journey, and this very successful journey. And I think all of us know that probably through the work that we've done with lean has really been something that made the transition to the Morris Hyman Critical Care Pavilion go as smoothly as it went. And that has really been something that was important, and really lean has supported the patient first ethic. And as we know, the philosophy and methodology are really around the continuous process improvement activities throughout the healthcare system. And as I said, lean certification training is something that takes a great deal of time, and it's a 12 to 18 month process. And really, it requires the individual to become proficient in lean concept and tools. And then at the end, that person is evaluated on their performance along the way. And as you can see, Dr. Achanta in these pictures had to lead certain value stream mapping workshops and participate in Kaizen workshops, and also lead them, as I said. So it is a great deal of time and effort, and for someone also who had a busy practice, it is something that we really appreciate him taking the time and effort to do. And as you can see, we've to date had 40 people that have been certified, and Dr. Achanta is one of 3 physicians. So I'd like to have Dr. Achanta come up, and then also maybe Dr. Stewart and Nancy, and we can present him with his pin and his certification.
Thank you. Where's your pen?
Thank you very much.
It's fun we're able to do that on an evening where you've been here with us.
Here anyway.
It's great. Great. Nice accomplishment. We're now ready for our quality report from Mary Boron. Mary?
Good evening, thank you. Tonight I'm going to be sharing with you about a database that we participate in here at Washington Hospital called the National Surgical Quality Improvement Program Database, otherwise known as NSQIP. NSQIP is a surgical database that was created for surgeons, by surgeons, to take all of your surgical procedures, put them into a database, compare them to national other participants that are inputting their surgery procedures, and using it based on a risk-adjusted value to look at the patient outcomes, which basically means risk-adjusted is looking at your type of hospital against how sick your patients are compared to other ones. So it is weighted a little differently because of that. The data is clinically validated, and it's benchmarked, which means it's compared against other people participating in the same database. This database is supported by Joint Commission, and it also fulfills our CMS requirement that we participate in such of a type of database. There's quite a bit of participants on a national and international level. 715 hospitals participate. Here in California, there are 69 hospitals participating. It continues to grow every year. The history of how it got started was in 1985, Congress passed a law mandating an annual comparative performance report for risk-adjusted surgical outcomes that the VA had to participate in, otherwise known as the Veterans Health Administration. And they sort of saw how this worked for the VA and realized that they were getting some good changes out of looking at this data after it was required. So it moved into the private sector. And around 2013, we recognized that there were some things that we could do if we participated in this database that would help us improve our outcomes. So we began participation. We recognized that there are basically 3 benefits. First and foremost, to the patient, Most of the hospitals participating noticed improvements with decreased morbidity, which is the illnesses and complications associated with surgery that could potentially happen. And 2 in 3 of the hospitals also noticed improved rates of mortality. So that would be a death after surgery. Most hospitals were able to show some decrease in that. Also, there are benefits that the surgeons can have from this. We share the data through peer review, and they can actually use that data and that outcome to improve their own surgical practice and care. The hospital also uses it as an opportunity to see where are we compared to other hospitals in the area, what are some other hospitals doing and collaboratives they're working on that they share with us. We go to a national annual meeting on this every year, and this is one of the places where we can hear about these collaboratives. So in general, there's a lot of benefits to participating. You can participate on many different levels. We started off small in 2013, but in 2015 we expanded our participation. So currently we have about 1,680 procedures that we abstract every year. This is a manual abstraction, and I'll talk a little bit about who does that and how that happens. But in each one of those procedures, we pull up 50 elements from the medical record. So you can see that those 1,680 cases you can actually obtain quite a bit of information from looking at those. The patient population is fairly large, just basically across all the surgical services that we offer. And we look at it in 3 different stages. So preoperative data, what was the demographic of this patient population, what was going on with them clinically when they arrived, what did their labs look like, so we have a good baseline for what the patient looked like upon arrival. What happened when they went to OR, so that area of the medical record is abstracted out, and it gives us a better surgical profile look at the case itself. But especially what NSQIP wants you to focus on is post-operative data, and that's what we spend a lot of our time looking at. What are the outcomes with these patients? What kind of complications do they have, such as surgical site infections or urinary tract infections? What happened after they were discharged? Did they see their physician? What was it like when they went to home? All these sort of things require a lot of follow-up, and we follow them up for about 30 days afterwards. It's, as I said, based on actual data that we abstract from the medical record, and it's reviewed on a physician level and on a quality level. But we also do another piece of comprehensive data collection that is, we send out surveys to these patients, and at first when I had heard, we send these things out by mail, we probably won't get back very many. We get back quite a few. We actually send a stamped envelope. This is what all NSQIP participants do. And quite a few of the patients actually do fill it in this is after their phone call and after they've sort of been hearing from us after their surgery. And they give us an overall look at their perception of how their care went. And so we've been doing quite a bit of that, and we've seen that come up from about 70% participants to closer to 80 in the last quarter. So in order to participate in this, you have to have a staff member, one dedicated staff member. That's something that CMS recommends and NSQIP recommends. And they require quite a bit of comprehensive training for that person. They have to go through 80 hours of training. They have to pass a competency exam. And then they also have to have an auditor look at sort of their data. We do some auditing just internally. We have 2 the people who abstract this, and they kind of audit one another in addition to sort of what NSQIP comes back with on their own audit. So I think that's helpful. We also work closely with the surgical champion physician advisor at our hospital. That is Dr. Pipkin. He's our quality physician advisor, a retired surgeon himself, and he looks at these cases very comprehensively, goes over it with the surgical abstractor and makes sure that what we're saying is appropriate to put in, so that way we get good data that is meaningful back. So that's sort of tracked on this slide. You can see that the data comes from inpatient and outpatient units, goes through, again, the 2 people I just mentioned, surgeon champion and our dedicated surgical clinical reviewer. And then we put that data into the surgical database, NSQIP, and then they send us back reports that we share in quality, send to the chair of surgery department, and then from there it's disseminated in the form of peer review to the surgeons. The way that we have used this data, I think, has overall been useful to us. Like I said, from a peer review standpoint, it helps us get the data out quicker to the surgeons. But overall, Another great aspect of it is that we've really been able to see where we are compared to other hospitals. Again, like I said, you have over 700 participants, so it's a good time to be able to benchmark yourself. And for a hospital of our type and size, we've received quite a bit of exemplary status, and that means that your hospital is in the top 10% for everything that I say is exemplary. So starting off with, on this slide, it's mortality. So our mortality was overall much lower than expected compared to these others. Ours is at 1.2. They expected us to be closer to 1.6. So that's actually statistically significantly lower for mortality. Overall complications, same thing. We have received exemplary status from NSQIP, and our complication rate overall was 4.0%. They were expecting a hospital of our size and type to have closer to 5.2. That's another great outcome. These complications can range anywhere from strokes to other complications that even can lead up to having to come back into the hospital and back into the OR. So we're lower there. And that gets into the readmissions. We have received exemplary status for that. We're in the top 10% of hospitals with the lowest rate for readmissions of the surgeries that were abstracted. That is 3.7 is our overall readmission rate for these surgical procedures. NSQIP is seeing something closer to about 4.9 is what they expected. So that's how we received that level of status for readmissions. And unplanned returns to the OR, like I said, so you expect on most surgical procedures, it's just one trip to the OR, and about 1.8% of the time we do have unexpected issues that may arise with the patient, and then they have to go back to the OR again and have another procedure. The NSQIP sees that to be closer to 2.2, so we actually have a lower planned return trip to the OR. Respiratory complications, another thing with especially like a more complex surgery where you might end up in critical care afterwards and have to be on a ventilator, the device that helps you breathe when you can't breathe on your own. And we received exemplary status for that with the lowest. They look at ventilators basically for if the patient is on for greater than 48 hours, then that's how NSQIP measures this particular exemplary status. And for us, we were able to have that at less than 1% of the time. So that's 0.3, 0.8 was the expected rate on that. We also received it with infection prevention exemplary status. Our surgical site infections in general at Washington are very low. And but we, in this case, even with NSQIP, when they compared us against other hospitals, we were at 0.8% when expected was 1.3. So exemplary status on that. And then they also will give you status level based on the type of service and the type of surgery. They can break it down on that level. We did receive this in general surgery, exemplary status for having a morbidity rate of 4.7%. This one's much better than what would be expected at 7.4%. So overall, a great outcome for general surgery. And cardiac surgery is another area where we had statistically significant lower morbidity, urinary tract infection, surgical site infection, readmission rate, and the ventilators. Overall, much lower on those areas also when you look at cardiac surgery specifically. Total knee replacements. I think we've heard a little bit about this already this evening about how great our outcomes are with that. You've heard and obviously seen and are aware of how large our volume is. We have received exemplary status from NSQIP on this surgical procedure based on the fact that we had very low VTE, which is basically this patient's developing a clot after surgery. Ours was 0. They expected it to be close to 1%, so 0.9%, and we actually did not have any in a sampled case of 425. So that's pretty significant. Our patients get up, they move very quick, they don't spend a lot of time in the hospital, they have a lot of pre-op teaching. Not surprising to see this, but it's a great level of success. Hip replacements, also we had lower rate of blood clots, infections, and readmissions overall for this surgical line, and that was out of 266 sampled cases. So where we look into the future with this is that we want to continue to utilize the information that NSQIP provides us with, which is to keep us in the most current best practices and make sure that that leads over to improved care at the bedside and in the OR. I think where we'd like to see us go with is NSQIP provides more and more every year. They're providing more comprehensive executive summaries and giving you an overall recommendation for hospital process, things like that. So we'd like to be able to share that further in this upcoming year with the clinical staff, in addition to the medical staff, sort of so it's not, you're just not looking at the peer review cases that you send. And we would also know that we're going to continue to participate probably on this max level of 1680 cases a year, because that has, we've really learned a lot from it. It's been beneficial. That's it. Thank you.
Thank you, Mary. It's impressive data.
I think it's important not to underestimate what Mary has just presented to us. I mean, this is really spectacular and stellar stuff. The first thing I wanted to say was that the exemplary status showed that we are statistically significantly better than expected. It's just not that we're a little bit better, but to actually achieve statistical significance requires a good deal of separation of us from the remainder of the pack. And so to see exemplary status in morbidity, mortality, complications, respiratory complications, infection rates, DVTs, all of these things are really important, because it says what we're doing here to improve the quality of care is working. Yeah. And working means that it accrues to the benefit of the patients and their families. That when you come here to have your surgery, you're more likely to go home. You're more likely to go home well and in good condition and have a successful outcome. So this is very powerful stuff. And I have to hand it to my surgical colleagues, the physicians who do the work, but they're only part of it. You know, the rest of it, sorry, Kranthi.
That's absolutely true.
Because when I see Kranthi doing rounds, he doesn't do it alone.
That's correct.
He does it with the staff. And it's teamwork that works together, meshes well, to make sure all of the right things happen before, during, after the surgery. So this is wonderful data to present, and I just wanted to make sure the community understood what you were actually presenting to us, because this is real. This isn't just marketing hype. This is actually real results, which means a healthier outcome.
Yeah, absolutely.
I'd just like to add one more comment to that. It's not just statistical significance, it is top 10%.
Yeah. Mm-hmm.
In all of those categories where we got exemplary status. And that's something else. Top 10% of all hospitals that participated in NSQIP. And there's, I don't know how many hospitals.
714 in the
714
nation.
hospitals
in the
nationwide.
world, yeah.
And growing.
Yeah. Well, and it's, we send the abstractor to Florida every year, like I said, for this conference. And she said literally the entire time she's there, people come up to her and ask her, what are you doing? You know, can we hear a little bit more about this? Because the people who have that level of status are listed and are announced there, and they get their award. And she says, I spend so much time talking about our processes and what we do. And so that in and of itself tells you something.
So as a board member, I want to say thank you to our surgical staff. Thank you to the nursing staff. Thank you to the administrative staff. Thank you to Nancy for creating the environment where this can happen.
Everybody's supposed to be focused on the same thing.
Mm-hmm.
And the same thing is doing the very level best we can for each and every patient that comes to us for care. And it's not about coming up with a financial target. It's about each patient and doing the right thing for them. And I think that's what the community needs to begin to focus on. That is the reason for not selling off your hospital district to a large chain. It is the reason for keeping your district here.
Amen to that. Thank you. Chris, we're ready for a financial report.
Okay, tonight we will be looking at Washington Hospital's operating and financial results for April. Moving into operating indicators, average daily census for April came in at 165.2. We'd expected 178.9 in the budget, and again, you can see the impact of those joints moving to outpatient. Admissions came in about 97 below budget at 990. Patient days were 412 below budget at 4,956. Outpatient observation equivalent days were 22 above the budget at 164, and our average length of stay was 0.49 higher than we expected in the budget at 5.43. Moving into operating indicators, case mix index for the month came in at 1.456. We had expected 1.476, so a little bit lower. Oh gosh.
Our audio visuals, Chris.
Oh, it looks like the plug fell out. Let me see, I can probably fix it, Sheree.
Sheree. Good job, Sheree.
Look out, Sheree, I'm gonna have to come after your job, buddy. Okay, we'll start this one over. Case mix index for the month came in at 1.456. We'd expected 1.476, so a little bit lower acuity than we had anticipated. Deliveries for the month continued lower than we've seen. 25 below budget at 121. Surgical cases for the month came in 8 above budget at 388. That includes our joint replacement cases that were 17 above budget at 168. Neurosurgical cases were 2 above budget at 26. Cardiac surgical cases offset that. They were below budget by 4 at 5. And that kind of rest of it rounded out by general surgery. Cath lab procedures for the month were 28 below the budget at 322. But our outpatient visits were 795 above the budget at 7,880. Emergency room visits for the month continue with the lower trend at 4,337 for the month. Quick look at the cath lab activity. Cardiac activity was the highest percentage of the pie this month at 38% of the activity, followed by peripheral vascular at 34%. Non-vascular interventional radiology came in at 23% of the activity, and neuro-interventional radiology came in at 5%. Moving in productivity, productive FTEs for the month were 2.1 below the budget at 1,367.4. We had 170.7 non-productive FTEs in April, giving us total FTEs rounding out at 18.5 below budget at 1,538.1. Our full-time equivalents per adjusted occupied bed, that is our productivity measure, came in 0.16 below the budget at 6.35. So based on the activity, our staffing was within budgets. Moving into the financials, and as always, we'll look first at the Governmental Accounting Standards Board presentation. This is the presentation all governmental entities are required to use when reporting their financials. Total patient revenue for the month came in 6.3% below the budget at $176,072,000. Deductions from revenue for the month came in high at 79.48%. Really driven by payer mix. Usually we've been seeing bad debt drive these numbers, but this month it was payer mix. For the month, our governmental patients made up 75.2% of our gross revenue. We had expected about 72% for the month. And, as we saw in the budget presentation, those patients don't pay the bills. And it really impacts our financials when that number goes up. Conversely, our private pay patients for the month, where we've seen an increase, were actually lower than expected in April. They made up 2.5% of gross revenue. And normally we look for something a little bit higher. That's not right. 1.2% of gross revenue versus 2.1% in the budget. So we're seeing some swings, starting to see some swings in the private pay bucket. We're seeing some clusters of high dollar uninsured cases that come in, and then we'll get a little bit of a breather. I think we'll see some of that in Nancy's report coming up as well, see some of the volatility that's starting to develop there. So anyway, we end up with net operating income from for April about $4.1 million, a little over $4.1 million below the budget at $36,737,000. Operating expenses for the month came in $739,000 above budget at $39,287,000. We had a number of offsets going on here. Our benefits were about $250,000 above budget for the month. Part of that is the pension adjustment we've been seeing over the last several months, but that number was actually offset by some favorable numbers that came out of our actuarial work related to workers' comp. So we took a little bit of a pickup to offset that in there. Supplies for the month were $224,000 above the budget, largely driven by prosthesis, and that, of course, was generated by our higher levels of neuro and joint replacement surgeries. Purchase services and pro fees were below budget by $367,000. This is a really good story. What's going on here is in our prenatal diagnostic center, our oncology program, and our special care nursery, the professional fees, as those programs build, the professional fees that are being collected by UCSF have increased, and those are offsetting the income guarantees that we provided in those contracts. So really, the growth of those programs is becoming very beneficial, and they are covering a good part of their cost. The other big story in April is we're back to depreciation. We have been booking depreciation on the Morris Hyman Critical Care Pavilion based on some estimates we had done earlier in the year. Now that the project is finished, we've had time to go through it in detail. Our estimates were a little bit lower than the final number, so we're going to be booking some adjustments to true that number up for the next couple of months. So depreciation for the month ended up at $749,000 above the budget. So we ended April with an operating bottom line showing a little bit more than a $2.5 million loss for the month. Non-operating income for the month came in $469,000 above the budget. So we ended the month with a total bottom line from a GASB perspective of a little over a $2.2 million loss. Moving into the Financial Accounting Standards Board presentation, do some accounting gymnastics here. We eliminate our tax revenue that supports the debt service on our general obligation bonds and the related interest to come out. We then reclassify the interest expense for our revenue bonds up into operating expenses, because that's where FASB wants it. So we end up with an operating bottom line from a FASB perspective showing a loss of almost $3.3 million for the month. Non-operating income ends up a little over $500,000. So we end the month from a FASB perspective with a net loss on the total bottom line of a little over $2.7 million. Quick look at our earnings before interest, taxes, depreciation, and amortization. The reason we look at this was articulated really well by Director Wallace a little earlier. Depreciation really is a non-cash item, and to really get a sense of how the operation's doing, you got to pull that out. So when we do that, this is based on our GASB presentation, we end up with EBITDA of just a little bit under $2 million. And then you combine that with about $2.2 million that are non-operating activities generated. We end up with producing income of about $4.2 million that we'll use to pay the debt service on our revenue bonds and future capital needs, or as Director Wallace put it, whatever else we need to spend money on. So. That's the month of April. Are there any questions?
I think it's important to emphasize that, as Director Wallace said, spend money on whatever we need to.
Yeah.
The money that we spend goes directly back into the district.
Absolutely, and that money gets spent on interest and our capital needs and the development of programs and. Director Wallace really explained it well.
Those aren't items that we're spending money on to do other things. These are
right. Or
good.
Paying to shareholders.
That's right. We're ready now for the operations report.
Okay, these are the preliminary results for May. Our gross revenue amounted to $198.5 million for May, just below budget by 0.2%. The deferred pricing adjustment, which we've been discussing over the course of several months, made up $9.2 million in a gross revenue variance and $328,000 in net revenue. Inpatient gross revenue of $139.6 million came in 6.8% below budget, but $16.8 million above the budget May a year ago. The outpatient gross revenue of $58.9 million was above budget by $9.8 million. That's a 20.1% variance and $11.8 million above May a year ago. And as we've been explaining all along, the shift from inpatient to outpatient, primarily due to the joint replacement surgeries being moved into the outpatient venue by Medicare, has everything to do with these variances. In terms of other major drivers of revenue variance, inpatient days were above budget by 34, and that drove our room and board revenue up by $1.8 million. But when you look at the deferred pricing adjustment, the offset to the increase by $5.8 million in gross revenue is what's not there. Emergency room visits came in below budget by 553. So emergency room revenue was down by $880,000. $3.4 million of our variance there was due to deferred pricing adjustments. Cath lab procedures came in above budget this month by 16, a 4.5% positive variance. And that drove our cath lab revenue above budget by $1.7 million. Surgical services cases were also above budget by 23 cases, a 5.9% positive variance, driving our surgical services revenue above budget by $6 million. Moving on to key census statistics, our average length of stay was 5.24, and that came in above budget. We had planned for 4.76. Outpatient observation days were 41 above budget at 182 days. And as you might recall in prior explanations, as we've discussed, outpatient observation, that's Medicare's way of securing inpatient care for their beneficiaries without paying inpatient prices. Average daily census of 182.1 was above the budget of 181.0, and that's a 0.6% variance. Admissions were 119 below the budget. They came in at 1,061. Major drivers of the admission variance include the inpatient joints moving to outpatient, deliveries coming in below budget by 22, and emergency inpatient medical admits coming in below budget by 31. Patient days of 5,645 were above the budget by 34. Total surgical cases in May of 411 were above budget by 23. That's a 5.9% variance. Inpatient surgeries were 70 below budget at 243. Outpatient surgeries were 93 above budget. And again, this is the shift that we've been talking about. In terms of surgical activity, cardiac surgical procedures came in below budget by 4 cases. Neurosurgical procedures were above budget by 1. General surgical procedures were above budget by 8. Joint replacement surgeries were above budget by 18. In terms of our cath lab trends, our procedures for May of 370 were 16 above budget. That's a 4.5% positive variance. Inpatient cath lab procedures were above budget by 44. Outpatient cath lab procedures were below budget by 28. Peripheral vascular procedures were below budget by 9. Neurointerventional radiology procedures were above budget by 2. Non-vascular interventional radiology procedures were above budget by 4. Cardiac procedures were above budget by 19. That's a 12.8% positive variance. In terms of deliveries, as we mentioned earlier, we were below budget by 22. We had 135 deliveries. Non-emergency outpatient visits of 8,168 came in above budget by 718. That's a 9.6% positive variance. The lymphedema clinic visits were above budget by 58. The prenatal diagnostic center visits were above budget by 61. These are both product lines that we've been working on with UCSF. Lab visits came in above budget by 100. Excuse me. X-ray visits were above budget by 119. Infusion visits were above budget by 123. Cardiac rehab visits came in above budget by 182. The emergency room visits of 4,587 were below budget by 553 visits. Washington Outpatient Surgery Center had 500 cases in May, 12 above budget, 2.5% positive variance. Our clinic visits of 3,739 were below budget by 323, negative variance of 8%. Washington Urgent Care was down by 208, Nakamura 50 below budget, Newark 195 below budget. Both Warm Springs and Ohlone came in above budget. Warm Springs were 40 visits above budget, Ohlone 90. In terms of preliminary payer mix information, it was unfavorable. Government-sponsored patient revenue made up 72% of total gross revenue. We had budgeted for 71.8. HMO revenue was 2.4% of gross revenue, which was below budget of 2.9%, by 2.9%. No, of 2.9%, I apologize. PPO revenue was 22.4% of gross revenue, which is below the budget of 23%. Private pay revenue was 3.2% of gross revenue, which was above what we had budgeted at 2.3%, and above last year's percentage of 1.9%. So you can see that's beginning to grow. Days cash on hand for May ended at 155 days, up 12 days from last month. We received $7.2 million in supplemental funds from the state. There was still $3.8 million of supplemental funds outstanding at the end of May. This is the prime program. We did go to funding pension and OPEB on a quarterly basis versus an annual basis, and the timing difference funding in April was $6.6 million. The days of gross revenue and accounts receivable were 51 days. That's a very good number. There were $1,638,000 in charity care applications pending or approved in May. I wanted to tell you a little bit about those cases. You can see this number is growing. We haven't seen a number this big in quite a while. 14 of the self-pay accounts totaled $3,952,000 in charges. 6 of these patients came from out of the United States. They're out-of-country patients. Their bills totaled in excess of $1 million. These are people who've come without funding source. This is a number that's going to get bigger and bigger as we head into the next fiscal year. I don't see it slowing down. It's been trending up throughout the past year. I want to give you our report on 1152 Senate bill. There were 232 homeless patient encounters in May. 28 homeless patients had more than one encounter. The estimated incremental cost of Senate Bill 1152 for the month of May is $71,000. The estimated total unreimbursed cost of homeless care for the month of May is $418,000. The estimated total unreimbursed cost of the homeless care we've provided in this calendar year to date, with the program beginning in January, is $2.5 million. It is what it is.
Thank you. Thank you, Chris and Nancy. We're now ready to move into our action items. Those will be presented by Dr. Nicholson. We're down to item C at this point.
Item C, Mr. President, in accordance with district law policies and procedures, I move that the Board of Directors authorize the Chief Executive Officer to proceed with the necessary contracts to complete the special care nursery upgrades for an amount not to exceed $169,250.
Second.
We have a motion and a second. Nancy, would you like to explain that just a little?
Yes, I would. I want to mention that the last time we remodeled the special care nursery was over 10 years ago at the time. We have UCSF contracted to provide the care of the physician services in our special care nursery, and they have made note that the unit is in need of some upgrades. And this is a rather modest project. We'd like the board to give it every consideration.
That program is moving forward nicely. Good. Do you, any board members have any questions? Dee, if you take the roll.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Wallace?
Aye.
Director Epen?
Aye.
Director Yee?
Aye.
Thank you. That motion passes. Item D.
Item D, Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors authorize the Chief Executive Officer to proceed with the necessary contracts to complete the Westcom nurse call system upgrades for an amount not to exceed $356,300.
And do we have a second on that?
Second.
We have a motion and a second. Again, Nancy.
Westcom is the provider of our nurse call system in both the main tower and in the Morris Hyman Critical Care Pavilion. When the nurse call system was specified for the Morris Hyman Critical Care Pavilion, it excluded a couple of accessories. One was a nurse locator and emergency communication capability that could be incorporated into the nurse's badge with the security issues that we've been having. And we're averaging code bursts about between 3 and 4 a month now. I think this is an important step to take to provide for the security for our employees. We've had a number of incidents involving very aggressive or abusive patients and or visitors towards the staff, and not just our employees. But we need to give the nurses the ability, when they need to communicate emergently, that we do this. And I think the most economical way to do it is to include it as part of the Westcom call system.
Thank you. Any further discussion?
I should add, we're going to be trading out money that was set aside for other capital projects because this was not budgeted.
D, if you take the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Epen.
Aye.
Director Yee.
Aye.
Thank you. That motion passes. Item E.
Item E, Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors authorize the Chief Executive Officer to proceed with the purchase of 7 Medtronic F10 electrosurgical units in an amount not to exceed $130,000.
Second.
Motion and a second. Nancy, would you?
Well, probably Cronty could speak to this better than I, but I will give you the basics. We did a trial.
He's excited about it, I can see.
Yeah, he's sitting right up. We did a trial, and this would allow us, one, to consolidate under one vendor. And this is something that's frequently used by surgeons for dissection and cauterization. We want to standardize the units. We use currently a mix of vendors. It is budgeted. And Cronty?
So we currently have more than 4 vendors, and what it does is it creates a lot of unused inventory that expires. Also, we're having a difficult time standardizing processes with the equipment. Sometimes wrong equipment is opened because of confusion and so on and so forth. So we had an energy fair where all of the 4 vendors were brought to this location, and the surgeons were asked to weigh in. And based on that, we've narrowed it down to one vendor with one product so that we can standardize the processes and eliminate a lot of waste. Again, lean thinking in the OR.
Great, great. Any other questions or discussion? D, if you take the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Epen.
Aye.
Director Yee.
Aye.
Motion passes again. Item F.
Item F, Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors authorize the Chief Executive Officer to enter into the necessary contracts to proceed with the purchase of implementation services and software for a patient estimate solution in an amount not to exceed $72,521.
Second.
And we have a second on that. Nancy?
This was not included in our fiscal year capital project budget, but I do believe that it is a very necessary addition to to information we can provide to our patients. It will enable our internal staff and ultimately our patient population to see and understand out-of-pocket expense for our services. It will take 7 months to install it. This is not an uncomplicated thing. And I don't want anybody to think that tomorrow it'll be available because you approved it tonight. But we will get it installed as subject to board approval as quickly as we can. It is something that is in demand. It exists at other hospitals, and we feel that we need to be on the leading edge of this.
Great, great. Any other questions on that? No. And we're ready to take a vote. Dee, if you'd take the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Eaton.
Aye.
Director Yee.
Aye.
We now have item G, which is a consideration of the Chief Executive Officer at-risk compensation. I'd like to make just a few remarks about that before we consider that. This item is a consideration of the at-risk award for Nancy Farber, our CEO. This award pertains to the fiscal year ending June 30th. A memo from legal counsel who has joined us here at the board table tonight, Mr. Kozachenko, a memo providing background information and also ranges for consideration of the amount of the award is based on the median and maximum target opportunities for the California peer group of other hospitals. That memo was posted on the district's website last Friday. The amount of the award is within our discretion as a board. And that amount, we were aware of the minimum and maximums that are among the California peer group of other hospitals in California. The amount of the award is totally within our discretion. And I'm inclined to support an award at the higher end of the range of those possible awards. I'm inclined to think of a range of in the 30% range, which is not the highest in the group, but it is above the median. I feel that way because this past year for the hospital has been a spectacular year. Very, very, very promising, wonderful list of accomplishments have gone forward in this year. And while staff and all of us work hard at that, I think a majority of that success is attributable to Nancy Farber and her leadership. Perhaps the major accomplishment of the year is the opening and finishing of the Morris Hyman Critical Care Pavilion. That's been mentioned several times tonight, and it's a spectacular place. I hope to never be a patient there, but going there, seeing that facility is a wonderful, wonderful addition to the district residents in this area. That building, as was previously mentioned earlier tonight, was in the planning stages for a very long time. But the state of California made some recommendations, made some requirements that any new hospital be raised to a very, very high level of seismic safety. And that required a lot of investigation, that required a lot of work, that required a tremendous amount of reevaluation, and it required a lot of money. The state of California required that all hospitals in California do that, but in their kindness, they provided no money to do that. And so we had to go to the district to pass a bond measure. Those are difficult things to do, and Nancy's leadership in that area was much appreciated, and the staff has done a great job on that, and that those monies were acquired to build that building. It's interesting to note that Dr. Nicholson, being an engineer in his past life, still would appreciate that the Morris Hyman Pavilion is built on a base isolation system. What that means is that building kind of floats, and it can withstand a very, very intense earthquake. Apple down in Silicon Valley uses that same system in their new building. So we and Apple have something in common. That building is a spectacular building to be in. It's a spectacular place to receive care. It's wonderful that that building was put there on time and on budget. A tremendous accomplishment. We have a world-class facility that is right among us now. In case of an emergency, we wouldn't have to rely on trying to get somewhere. We have it right here. And I think that's a tremendous accomplishment. Several times also this evening, we've mentioned the affiliation with the UC system, and some tremendous progress has been made there. The oncology department at UCSF has recently been recognized as the #1 facility in California. And we now on this campus have physicians from that world-class facility to treat patients here in this facility, rather than having to travel great distances to do that. That is a tremendous accomplishment to have that available to the citizens of the district. And Nancy is primarily, I believe, responsible for establishing that relationship. She's had the foresight to strategically position our hospital to fulfill its mission in a very, very effective way. So I feel very strongly about her qualifications, her deserving this at-risk compensation for this past fiscal year. I'd open that now to any public comment, that anyone that else wants to comment on that. If not, I'll close the public hearing. I'd like to hear from any board member that would like to comment on that issue before we consider voting on that.
Mr. President, I would agree with your remarks as far as the stellar year that we've had under the leadership of Ms. Farber. I'll make it brief. Morris Hyman, on budget, on time, smooth move in, appreciated by everybody in the house. It was delightful. Nary a hitch at all. The hardest part was to find your way around the big facility.
Yeah.
We're still learning. The second thing is the expanding relationship with UCSF. It's paying off in terms of excellent care for our patients. It's nice to see those UCSF oncologists, Dr. Bogdan, Eftemia, and Dr. David Lee care for our patients, and I'm sure you've had your patients enjoy that benefit and the wonderful gifts that they can bring. The third is solid, stable financial performance in an era of unpredictable uncertainty. We can't even, it's one of the unknowables as far as what's going to happen as far as the healthcare financial environment. Yet we've had stable financial performance, which I think accrues to the patients and our ability to grow our programs. And then the fourth is the growth of the hospitalists within the hospital. Dr. Achanta is one of those. He's a surgical hospitalist, but we have internal medicine hospitals, we have intensivists. And this just results in an order of magnitude better performance within the hospital as far as having the right people there at the right time, making the right decisions for the patients. So that's a very important thing. And then finally, the growth of the Washington Township Medical Foundation, which grows the outpatient environment for our patients. So given all of that, I also agree with a award in the 30% range.
Yes, let me just add, you guys have taken just about every talking point I had, but I just want to say that there was plenty of issues that one could be distracted over in this fiscal year that's ending this month. But those items that you mentioned, particularly the Morris Hyman Pavilion and all of the other moves that Nancy has made strategically, has not affected the financial performance or the quality. We have heard ongoingly about the high quality of patient care. And this being Nancy's final year before retirement, I think it's one of the things that I note in the legacy that she leaves is her focus on strategic thinking and strategic doing. When I met Nancy in 1990, when I came on the board, she was in charge of strategic planning, and we were blessed with the ability to have Nancy come on as a CEO, and with that background in strategic thinking, lead us through some very changing times in the last 25 years, and got us focused on not being comfortable with doing business the way that we've done it last year or last month or even right now. Had her staff and the medical staff and ourselves focused on the future. And right now we're very comfortable with what we have in a management team because of Nancy's leadership. The idea that we have a patient-first ethic, what I would say the families of the patients are a close second, the community at large third, the staff of the hospital fourth, the doctors fifth, foundations sixth, it's all in there somewhere. But I know one thing for sure, Nancy is dead last. She is a selfless leader who has shown great courage and intellect in leading the hospital over her time here. And this year is really, in my estimation, no different except for the fact that there were plenty of distractions. And Nancy and the team overcame those distractions. And so I'm very comfortable in awarding the 30% at-risk award.
May I say something?
Yes, please.
This is all new to me. I've been here for a hot minute, but what I have appreciated in learning about what goes on, especially with you and preparing for your retirement, I appreciate what you all have said about what I already had an understanding of, a deep respect for your intellect and your ability, your thinking. But what I love the most is your heart. And that's what I saw first as a volunteer, that the CEO is coming to a volunteer lunch and she's speaking and appreciating us. And that was just a glimpse of who you are. And as I've spent more time at this level, it's only solidified and affirmed what I've already known about you, that Washington Hospital is the kind of hospital we want it to be because there's somebody in leadership that cares about the community and wants the best for the residents of this district. And you may have the intellect, you may have the ability to think above and beyond and bigger than a lot of us can think, but it's your heart that I really appreciate. And if it could be a bigger award, I would want it to be a bigger award, but they hold me back for good reason. But anyway, I just wanted to let you know what I appreciate about you is your heart.
Thank you very much.
All right. Nancy, I really don't have anything much to add. My colleagues on the board have pretty much well explained everything. They pretty much mentioned a couple of the organs, the intelligence, the brain and the heart. And but we have done this incentive award every year as a board, and really every year we haven't really had much of an issue because you have pretty much met all the indicators very well every year. And like some of my colleagues said, this year was slightly different. You have had more issues here, so I have absolutely no problems in awarding the higher end of the range, which is about 30%.
Good. Thank you all. Dee, I believe we're ready for a vote on that. I'm sorry, we need to make an action first.
So, Mr. President, I'm pleased to make the following motion. I hereby move that the board award at-risk compensation to the CEO based upon its compensation philosophy in an amount equal to 30% of base salary, which equals $262,180.
Second.
We have a motion and a second. I believe we've discussed that item thoroughly. Dee, if you take a roll, please.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Epen.
Aye.
Director Yee. Aye.
That motion passes. Thank you, Nancy. We now have item H, and again, I'd like to make some preliminary comments on that and introduce it a little better. Item H is the consideration of the Chief Executive Officer Employment Agreement. This agenda item is to approve an employment agreement between the district and Kimberly Hartz for the position of Chief Executive Officer. The summary of the key terms of the agreement are described in a memo from our legal counsel. And that was posted on the board agenda on the district's website last Friday. At the May 8th meeting, a month ago, the board designated Kimberly Hartz as the successor to Nancy Farber. The board took this action after receiving Ms. Farber's notice electing to terminate her employment as of October 28, 2019. Pursuant to Ms. Farber's employment agreement, Ms. Farber has the right to terminate her term terminate the term of her agreement with 180 days advance written notice. Upon receipt of the notice, the board had the option to ask Ms. Farber to relinquish her duties as CEO before the end of that 180-day period. This option allows the board to alter the 180-day period in order to effect an efficient and optimal transition. Given that the fiscal year for the district runs from July 1st to June 30th, it makes some sense to have Ms. Hartz take over as CEO at the start of the fiscal year rather than have her start into the middle of the next fiscal year. Ms. Farber has no objection to this proposal, and Ms. Hartz is willing to start on July 1st. So the term of Ms. Hart's employment as Chief Executive Officer will begin July 1st, 2019. It seemed more efficient and more optimal for the district to do it in that manner. Is there any, I would open that now to any discussion from the public. And again, seeing none, I would close the public hearing. I want to say that this is a very strange moment, a very call it interesting moment. This board has worked with Nancy Farber for our entire time here on the board. She's guided this district through many difficult times and has provided unwavering loyalty to the district. We've seen that tonight. We have all come to rely on her leadership. To say that she will be sorely missed is a very trite statement, but it's absolutely true. We will have a more formal and appropriate recognition of Nancy's accomplishments at a later date. But with this new time schedule, this moment in time is one of the last times that we'll be meeting with Nancy as the CEO. And I would like personally to thank her for all she's done. I've served on the board for 16 years. She's been CEO for 25. And there's a lot I don't know about what went on before I was on the board. But from my perspective, from what I know of what's happened here at the hospital, we could spend many, many, many hours going over the dedication and the hard work and the amazing accomplishments of Nancy Farber. She's wonderful. We also look forward to working with Kimberly. we know that some major challenges await us. We've talked about a few of those here tonight. We've talked about how challenged we can be at times and how unknown things can prop up that we had no idea were even there. But I want you to know that you have our firm commitment to work with you to continue the mission of the district, which is to preserve this hospital as an independent community resource, providing the highest quality of health care to our patients and residents. We will continue that mission. We appreciate your willingness to serve. Are there any other comments that board wants to make on this issue of the employment agreement with Kimberly Hartz? Seeing none, we'll now have Dr. Nicholson present that action item.
Mr. President, I'm pleased to present the following motion. I hereby move that the board approve the proposed employment agreement between the district and Kimberly Hartz for the position of Chief Executive Officer. The term of the agreement is 4 years, consistent with the practice of the district related to its chief executive officers. The term begins July 1, 2019, and ends June 30th, 2023. The President of the Board is authorized to execute the Chief Executive Officer Employment Agreement consistent with the action taken here tonight.
And I need a second. We've got a second. Any other further discussion on that tonight? Dee, if you take the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Epen.
Aye.
Director Yee.
Aye.
That motion passes. Thank you again. We're at the end of our agenda tonight. We appreciate all that have brought things before us tonight, all the work that's gone into this. We'll now adjourn to a closed session. We're ready to reconvene to an open session. Announce that no reportable action was done in the closed session. There being no further action this evening, this meeting is adjourned.